Now that we are recording, I know some instructors go over some of the tests, some instructors go over all of the tests. From my understanding, a lot of them will only go over it if a certain amount were gotten wrong. Is that correct? Is that still happening? I'm not saying it's wrong or right. I'm just curious. So like if 60% of the class got 10 wrong, they'll only go over those 10. Is that true? Maybe they changed it.
The last time they went over the whole, oh, sorry.
Okay, that's good. They went over the whole thing. Okay, perfect. I like that because I think it's a huge learning experience. So really that is a bulk of our class today. And then we'll go over a couple new terminology and a few new medications. And I am working currently, I think I put on your announcement. I can't remember which, if it was you or Mission College, but I'm currently working on a poster board of kind of making, and you can find it online, but I want to do it and post it of, like the different mood disorders. And we're going to like kind of start blocking things out so that what is a mood disorder, depression, and you had a couple of those on your test as well as the medication. I love you too, Katie. Okay. All right, so let me go ahead. So my one thing about the test, which I don't see that there's going to be a problem with, is that I'm happy to go over it. We will spend time on it, as much time as we need to. However, if it starts to get out of hand, which again, I do not see that happening with this group, we will stop. So if it becomes volatile or argumentative or that, kind of, I don't think I need to explain more because it's probably happened. You probably have seen that before. We will stop. That's never happened, so I don't anticipate it. So let's go ahead and let me share my screen with you. And please feel free to ask questions and let's get the most out of this. This is a huge learning experience. And then the other stuff that we're going to do is pretty straight to the point, easy. Don't look at that. Don't look at that. Okay, look at this. Can you guys see the test? Kind of, I'm opening it. Can you see it? Lazuli, you're on my screen. Can you see it?
No, it's a black screen.
Really?
Yep.
Are you lying, Andy? She's like, you don't believe me?
It says you started sharing, but we don't see anything.
Okay, maybe give it a second. My computer, for some reason, it's doing that thing, where like it spins. That's so weird.
Hey, Amanda.
Yes.
I had a really quick question.
Of course.
Are you finished grading all of the tests?
Okay, I have 7 left. I'm so sorry. So as soon
Okay.
I did 13 when I got home right now, and I have 7 left. I usually am like that with them. There's so many of you, and I don't know how many of you know I'm feeling much better, but I was in the hospital. I was pretty ill, nothing having to do with COVID. So I got a little bit behind. That's why some of the questions look like they're in Spanish. And my spelling isn't really on it. I have to laugh at myself at that a little bit, but usually I'm much better at not. I'm actually, this is a perfect example. I'm taking Seroquel to help relax my body because I had I think most of you know I had a internal hemorrhage basically, but I'm okay. This was like 3 weeks ago, I think. My clinical group, they're so amazing, holding my purse and being so sweet. Okay, let me try again to share. It should share. I'm doing everything the same way I always do. Do you guys see the test now?
Nope.
Seriously?
Yep.
Okay, that's okay. That's okay. Even if I have to read them out loud, we'll make this work. I'm not gonna waste too much time on it. If it doesn't work, I'll read the question and we'll talk about it. That's so strange. It says I'm sharing. Let me just try one thing real quick. Let's exit the full screen. Let's do that. Nope, don't do that. Cancel. And just let me know if you do see something. Someone say stop. please. That's so odd. I wonder why it's not sharing. That's so weird. Okay, I'm gonna try something else. I'm gonna share a different screen just to see if it's because it's this. Maybe there's some sort of like something. I have no idea. Let me try to share something else with you. Where's the Quizlet? Well, if I didn't have 500 windows open, maybe that would help, huh? Sorry, guys. I was completely ready. I was so proud. I have someone else's test open. I could use that. Okay, so Jihad, tell us a story while I'm looking. Jihad.
Um, so
Tell us a fun clinical story.
Kenny is an official bodyguard
He
for the
is.
state of California now.
Yes. Why is
Because
that?
he protected Amanda from being attacked one day. Kenny's officially a bodyguard.
Yes, he is.
End of story.
Very, very hyper vigilant, which is amazing.
Hypervigilant. What does hypervigilant mean, guys?
Excellent.
Extra aware of your surroundings.
Oh, yes, yes.
Who answered that?
Nicole.
Very good. You're not even in my thing. You cannot close the Zoom. I'm so sorry. I do this every day. What is happening? Keep going, Jihad. Teach the class.
I'm gonna need a check cut if I'm gonna keep teaching the class.
You said you wanted to be the TA.
Did I? Really?
Well, no, the leader or something, and then you were like, "Well, I want to be called assistant."
Andy said, "What's my in and out order?" Okay, I could talk about it.
Okay, go ahead.
Okay.
Do that. I think I've almost got this figured out. Keep going.
Yeah, so when I go to In and Out, I get a number 1, double, animal style, fries animal style too. And you gotta make sure you put chilies on there. If you don't put chilies on there, you might as well not go to In and Out.
Exactly. Agreed with that.
Am I the only one that gets well done fries at In-N-Out?
I get well done fries.
It's just better.
They're
Animal style's like if you have a
Right.
hangover.
It's so much, right? Well, I don't eat. Isn't there meat on that too?
No,
Oh, okay.
it's like cheese and onion, grilled onion,
I've
and
never
like a
had it.
slab of cheese. It's good. You
This
eat
is
it with
all-
a fork.
And now you can get a whole grilled onion if anyone knew that. I recently found that one out.
What? See, you learn more than just mental health in this class. Okay. They at least 2 or 3 people from my clinical group, this current one, because there's an In and Out right here, actually right by my house, which is funny that they go to after. Can you guys see the screen now? You can see the screen. Okay, so we're just gonna do this part first, and then when we take the break, I'll figure it out. So we can all see this. The Quizlet. Okay.
Yes.
So the first part of this class, thank you. And thank you, Jihad, and everyone else for being patient and whatnot. We're not going to be here till 4:15, just FYI. Not that I'm trying to keep it short, but just because of, again, there's a method to the madness of where we're going. So starting next week, we kind of hop back on the wagon of diagnoses. So what we're doing today is there are some terms on here that I'm going to say. For example, you'll notice I did slash instead of adding new ones. So I'm going to say right now, neurotransmitter, we all know that's how the brain communicates, so that you don't have to say that. And then there's some new things. I'm going to open the chat too. Sorry. I closed the chat. Oh my goodness, you guys. Is she recording? I should be. Yeah. I am, right? Yeah, yep, it's blinking at me. I'm recording. Definitely, especially for those who aren't here, for when we go over the test as well. And this is important. So I'm going to mention this about what we're doing right now. So for the next quiz, if you guys didn't notice on the test that we had, I reuse questions. So I do that for a couple of reasons. Number one, as I've mentioned before, I do really think repetition is important and seeing things over again. Yeah, I mean, it is nice. I think a little, I remember instructors doing that. I mean, like, thank you, it kind of gives a little bit of a leg up. And it does hopefully kind of drill it into your mind. Drill it into your mind. I haven't eaten all day, sorry. But the main thing that I want to talk about, like for instance, when we have our final, you're going to probably see, so let's say our final 75 questions, let's just pretend. So if you notice, this last midterm was 36 questions, but worth 50 points. So this next one might be worth 75 points, but 50 questions. Because like on some of them, like the therapeutic communication, and you all got at least a 4 and no one got less than a 4 on like that one. So I'm whatnot. So, but because I'm feeling much better for this one, who knows, maybe I don't know. Well, I'll have to see what the guidelines are because there are actual requirements of how many questions they do have to give you. But please, please, please look back over the NCLEX questions, look back over like these. I'm telling you right now. So I'm saying it out loud. Witnesses, things that we're talking about right now will be on either like if our next topic is, it actually might be addiction, right? It's addiction next, I think. If we do anything about addiction, that might be on your next quiz. So really, and I do my little study guides for you guys anyway, just so that you don't waste your time studying a bunch of stuff that you don't need to, because we don't really have time for that, right? So please, 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 and you can find my thing. I don't know how to do it, but if you guys do, if you can find this, I know other students have done it, they can find it, but I don't give the answer. That's the only thing. So just please, we're going to go through this real quick. I'm going to teach a couple things from it, but please remember what it is because you're going to see it again. And I'm literally explaining it and giving you the answer and making the connection. So that's really what I want to say. So neurotransmitter, again, we all know, and we know why it's important because a lot of medications, what do they interact with? Neurotransmitters. So a neurotransmitter is how your brain communicates. Neurotransmitters are where medications that work on the brain. So for mental health and or insomnia, where do they go? They go into the brain. That's how they work. So the most important thing to know is neurotransmitter. That's how your brain communicates. That's what's important. And we all know that. Now, the new thing I put on here is, do all mental health diagnoses require medication and or medication for life? True or false?
False.
Exactly. And it would be false because, and I kind of asked this on the test, and you'll learn more hopefully from my chart when we go over it, and I'll post it. I may actually just do an extra video and post it for it'll be like a 30-minute video. And that's because not everything, number one, some things like anxiety can be treated with therapy, certain techniques. And as well as some medications might be used in the beginning just to kind of help somebody, we've talked about this, kind of calm down, come to a good place, or help their brain be able to rebalance itself. It just depends on the individual, but it's really important to know that not all mental health diagnoses require medication for life. That's the important part. However, what is the one that definitely does? There's one specific that is absolutely chemical.
Is it schizophrenia?
Yes. So that is something that you would want to really take note of, schizophrenia. We will talk more about bipolar disorder later, but we haven't gotten there yet. Bipolar disorder We'll talk about it when we get there. I don't want to overfill, but definitely, unfortunately with schizophrenia, it's a biochemical, not saying that depression isn't, but depression isn't always, right? We've talked about that. It could be circumstantial and something happened, you're depressed, and because your boyfriend, girlfriend broke up with you and you're feeling a certain way. That doesn't mean you can't take medication, but just saying it's not always chemical. Does that make sense to everybody? So schizophrenia cannot be treated without medication because why? What neurotransmitter is too low?
Dopamine.
Exactly. And you'll probably see that on your final as well. Very good. And we will not go over all 41 of these like this. I'm going to skip some of them. And see that thing turning? I don't know what, I think my dog did something to my computer. Okay, so off-label medication use, we understand what that is. And we understand that it's basically a medication being used for a different purpose. By the way, what we're doing right now is recall. That's why it's like, why are we doing this? We've done this before. But then I added something to it. So my question to you guys is, do you know when a medication is prescribed off label, is it FDA approved? So if I prescribe propranolol for anxiety, is that considered FDA approved use? It's not. So we're still allowed to do it. And I mean, I've never seen a case where there's been anyone sued or harmed or anything like that. It may not work and they may need to use a different medication, but I think that's something that's important to understand, that if you use something off label. So if I use propranolol as a beta blocker because you have high blood pressure, that's FDA approved, correct? But if I use it on somebody for anxiety, it's not FDA approved. However, I'm still allowed to do that. Excellent example today, as we move on here, is at the VA, someone was prescribed, they were just extremely medication resistant. It was really, I mean, just poor thing had been there for like a month and just nothing was working. And and I know a month isn't a long time. I mean, it is to be on a psychiatric unit, but for medication, sometimes it takes longer. And they actually started giving a little bit of Adderall because his depression was so bad. And the students were really taken back by that. They're like, oh my God, they put him on Adderall. It was a very low dose. And I said, actually, sometimes we will do that, which I'm not going to test you on that. I just wanted to give that as an example. Sometimes we just run out of options. We're like, I don't know what else to do. What else can we do? And Adderall, you will learn more when we talk about addiction, but it's a stimulant if you're not aware of that. And yes, it is usually used for ADHD. However, it can help with energy. And if something else isn't helping, this can actually help. I have seen it work before. So that was just like putting an example, hopefully to help make that point. Okay, so now we're going to kind of move into some things that we have not talked about yet, but we will. So if you do not get this right now, that is okay. We're making a video. I was going to say, as far as going on, you could just rewatch the video and it has the questions. But so true or false? So first of all, what is a controlled substance? What does that mean? This is preparing me for the addiction lecture. I guess I just said it right there.
I was going to say, does controlled substance mean that it is habit forming?
Exactly. And they very good. They say it in two ways, and you'll hear me say interchangeably as well. So controlled substance has the potential to either be addictive or I don't know why I did that, addictive or habit forming. I say it both ways, however you prefer, totally fine. So a controlled substance, and you don't need to write this down because we will go over this when we talk about addiction, but I'm preparing you, kind of giving you a glimpse into what we will be talking about. And then more so, I really hope you guys watch the videos and yes, that is the love of my life, but more than that, it's just really interesting to most people because it's something that has affected a lot of people. Whether yourself or somebody that you know. So absolutely correct. So controlled substance has the potential to be addictive or habit forming. There are 5 So controlled basically substances in the United States. So in order for something to be considered scheduled, so it's interchangeable. They're either called scheduled medications. I don't like to call them that because when I hear that word, I think it means you take it on a certain schedule, but I want you to be aware that you may hear that term. So controlled substance, and now watch, you'll hear me say scheduled all the time now that I just said that. But a controlled substance, there's 5 types, schedule 1, 2, 3, 4, and 5. And again, right now you do not have to remember this. I'm just introducing it. So it's hopefully more easily taken in when we do talk about it, so that we don't have to spend as much time on it, because this addiction is, in my personal opinion, addiction, bipolar, and what's it called? That other one, borderline personality. Those are the 3 most kind of like, big ones. So does anybody happen to know? So schedule 1. So first and foremost, a scheduled substance must be prescribed in the United States. It must, and we're in the United States, so that's what we're talking about. It must be prescribed. So if you go to the, CVS, Walgreens, wherever, and you buy a medication over the counter, that is not considered controlled. Now, if you go somewhere outside of the United States, I believe, please, I'm sorry if I get this wrong, but a lot of my patients will fill me in. I think it's in Mexico you can buy codeine over the counter. I might be wrong, but I know there's some places that you can buy codeine over the counter. Here you cannot, because that's considered a controlled substance, because it has the potential to be habit forming or addictive. And I will teach you what that means, because it's not just, there has to be an actual evidence-based way to know whether something can be addictive or not. And I will teach you how we know that, because I think that's really important, not just to say, oh, it just is. Well, why? And I'll teach you that. So there's 5, schedule 1, 2, 3, 4, 5. And just in brevity, schedule 1 in the United States, we do not use for medical purposes. So that would be like heroin, cocaine. Alcohol is not on it because it's not considered a medication. Or not a medication, but it's just, I don't know why it's not on there, to be honest. It's just not on there. I think you guys get the gist. We don't like prescribe heroin, right? LSD at this point, we don't prescribe. So anything that's not prescribed for medical use in the United States would be considered a Schedule 1. And the only other thing I'm going to say about it right now, because this isn't our topic for right now, you don't need to worry about this one right now, is as it goes down, it gets supposedly, and we'll talk more about that in my opinion, less addictive in the realm of the potentially addictive medications. My example of that would be a Schedule 2 would be Adderall. Schedule 3 would be like, I don't want to get too far into it. Like Schedule 4 would be like Ativan, and then Schedule 5 would be like the least one. That's like, what's that one that makes you stay awake? Navigil. I always say it wrong. So we'll learn about that. But I feel like it should go the other way, but it goes that way. So just keeping that in mind. But you don't need to remember that right now. We'll talk more about it later, but at least you got a glimpse of it. So you'll hopefully be able to take it in a little bit quicker when we talk about it. So the next one, and again, we're not going through all 41 of these, so please don't get too like, oh my God, we're going to be here all night. So as I just said, do controlled substances need to be prescribed in the United States? Someone other than Nicole. Nicole answered the last one. And I think Lazuli said something.
Yes, they do.
Excellent. Yes. So controlled substances or scheduled, that's both correct, need to be prescribed in the United States. Can a Schedule 1 be prescribed in the United States? No, because that's like heroin, cocaine, that type of stuff. Okay. What is the difference other than price of a brand and generic medication? I think this is an important question. I think a lot of us may not think about this. Does anyone know? I actually asked a pharmacist, and my friend's a pharmacist. There's a couple reasons, but price, of course, but actual chemical wise, like what's in it and how they do that. Does anyone know? It's really interesting, actually. Or I think I'm a nerd, so I think it's interesting. So the basic reason, and this is all you would need to know, is, I mean, of course, price, we know, but what you would need to know is that the difference between a brand, so let's say you went to get Benadryl, for example, and actually, no, let's use a different one. I always use Benadryl. Yeah, okay, Benadryl is just the easy one. So you know how if you go to Walgreens, it's called Waldrill, right? Or if you buy the so generic one would be Waldrill, and then the brand one would be Benadryl. So the difference between a brand medication, and of course there's different ones behind, the patent and all that I don't care about. Generic and brand is that the active ingredients in the medication are the exact same. They must be the same, the active ingredients. The inactive ingredients can be different. And I will give you an example. So the medication NyQuil, I think we're all familiar with. If you were to open that label on the back, they tape it. It's annoying because it always rips. But if you look carefully, and you got like a generic one and a real one, and I've done this just to make sure, and I've looked at it, all of the active ingredients are the same, and then it's the inactive ones that might be different. An example of an inactive ingredient in NyQuil, just for fun, is alcohol. So the reason they put alcohol, does anyone know why? It's not for sleep. I don't know if I've mentioned it before, and you don't need to know this. It actually works as a solvent, so that all the medications that are in there for as a decongestant and to help you sleep, what actually helps you go to sleep in NyQuil is called not diphenhydramine, but doxylamine. You do not need to know that. I'm just telling you. But most people think it's the alcohol. The alcohol is an inactive ingredient. Doesn't mean that it doesn't work, though. I mean, if you drink the whole bottle, you're gonna get almost a bad word, really bad word. You'll get messed up. And you will get a DUI. I mean, it's not good. So of course we need to be careful with that, right? So if I asked you on a test, what is the difference that I taught you in class between a brand medication and a generic medication? The answer would be the inactive ingredients are different. Right? And, or I could flip it and say the active ingredients are the same and the inactive ingredients can be different. And that can matter for some people. So like, let's say you're taking a medication like Abilify, and now they have the off-label brand, which I always forget what the damn name is. Oh, let's take Zyprexa. The Zyprexa and, oh my God, what's it called? It starts with an O. Olanzapine. So olanzapine is generic. Zyprexa is the one that is brand. Some people actually, they will respond differently to the medications. So sometimes you'll go to the pharmacy and you've been taking the brand one forever and it's just perfect. And then they'll give you the generic because they're out and they don't even have to call the pharmacist to do, or the physician. Some will, some won't. And you may not actually react the same way, even brands of medication. So you know how sometimes they're blue, sometimes they're white, if you've ever taken a medication. So just keep that in mind. That I won't test you on that, but keep that in mind that it can be as sensitive as the manufacturer and or if it's brand or generic, the way you take that in. I've seen that a lot with birth control personally when I worked in OB when I first started being a nurse. So do we all understand what is the difference between brand and generic if I ask that on a test? Okay, thank you. And it's interesting, right? Would you have never, I mean, I was like, it was very interesting to me. Okay, we all know this and you all got, I think every single person on the test got this right. Where's 90% of your serotonin? It's in your gut, right? We know that. True or false, does serotonin have to do with feeling full? The only reason I put full is because I couldn't spell feeling satiated. So this is important for addiction when we start talking about it. So remember, your neurotransmitters do many, many things. Is this true? Does serotonin help you feel satiated when you're eating food? Does it help you feel full? I see heads moving up and down. That's good. That is true. So serotonin does help with that. But what I want you to remember for, I believe it's next week. I looked right before I came on here and I now cannot remember. When we talk about addiction, that has a lot to do with addiction as well. So what happens is when we talk about addiction, serotonin plays a huge role, which most people don't know. Your serotonin drops. So if you're having trouble feeling satiated because of a neurotransmitter being low, this is one out of like many reasons addiction happens. Don't you think that that might be hard because you're never going to feel full? So that's why we say enough is never enough. I need, for one person, they could have one beer, but the one person might be like, I need more, I need more, I need more, I need more, I need more. And other people don't understand that. This is just one reason. We'll talk about more reasons why. But again, I'm preparing you for this topic. So, and it also has to do with feeling full while you're eating. So does serotonin help with mood? Yes. Right? Do we all know that? Does serotonin help with feeling full when you eat? Yes. And does serotonin have something to do with addiction? Yes. Hold on, I'm looking down. I don't want to be that mean professor. There are literally 3 faces on here. 1, 2. There's another one. Thank you. I have to show like the way I look right now. Come on. Be with me. We're not doing all of these, I promise. Okay. So we all know the books to diagnose. You all got that right. Excellent. Can we still prescribe a medication to someone? This is very important. So I would like someone to answer this. And actually now I'm going to be the mean professor and actually calling people. And if you get it wrong, you get it wrong. It's fine. So can we prescribe a medication to someone if they are not diagnosed with a particular diagnosis, such as if, let's say somebody is presenting to a physician as anxious, can we still prescribe a medication for anxiety? I'm going to call on Andy P. What do you think?
Yeah.
Yeah, exactly. And it's okay to get it wrong, by the way. Like, and I won't ask the question if we've never like even gone around the realm of talking about it. That's how we learn. You are absolutely right. Excellent job. So we can still do that because we want to help with the symptoms, and hopefully we'll give some breathing techniques and whatnot. And then we see the patient again, because people are, may present differently after being on the medication for a couple of weeks, and then we can rule out different things. Because again, for example, mania, ADHD and anxiety, don't they all look pretty darn similar? They look pretty similar. So that could be hard to rule out. So we want to be able to do that. Good job, Andy. Is Andy P the one?
I have a quick question on that actually.
Yeah, no, please go ahead.
Yeah, so the reason why we can prescribe medication is because, is it just so that, for instance, if we were trying to understand a diagnosis, that it just helps rule out other different diagnoses?
That is excellent question. So yes, that is a correct answer, as well as, for me, honestly, that's how I say it. But you will hear other people, like physicians, I'll hear them say, I'm just trying to help you because you're super, super anxious, depending on the situation. So let's say, like, if one of my dogs died, I would be a mess. I would be so anxious that I could probably not even speak. So I would be prescribed probably some type of anti-anxiety medication for that period of time for that. Now, what you're saying is absolutely correct. It helps rule out other things. So for example, and that's one of my questions on here, so you guys could actually write that down right now. We can knock that one out. Is, let's say somebody is, I can't remember if I taught you this yet. So let's say somebody is bipolar. We have not talked about bipolar, but this is important. I think it was on your test. And we gave them something that had to do, but I didn't know. I didn't know. because they were presenting manic. However, I'm sorry, let's say they were bipolar, but I was thinking, oh, they're depressed and anxious because it looks so similar. And I gave them something that interacted with serotonin. So if you give somebody something that interacts with serotonin, which could be what? An SSRI, an SNRI, so usually an antidepressant, to somebody that is bipolar, what can that potentially cause? Did I teach you guys that? I did, right, on the test. It can.
Stomach aches.
What else? Say it.
And like induced mania.
Induced mania, exactly. So that would rule potentially. I mean, we don't want to induce mania. That would definitely not be our goal, but that would potentially rule something out, and that can happen. So that you definitely want to remember. So what you just, sorry, your name is now off. Who asked that question?
It was John.
John, thank you. So what you said is absolutely correct. Prescribing the medication can help, because what if they came back and you gave an anti-anxiety medication and they're doing much, much better? That tells me a lot. And talking to the patient, getting information, because that is absolutely key. And especially if you have done your rotation thus far in mental health, I think you'll have even a better idea. Hopefully you guys are starting this week, should be the second group if you haven't started yet. But please, please, please remember that it is contraindicated to prescribe something that interacts with serotonin to somebody who is bipolar. There is, of course, always the outlier. So if I asked you on a test, is this contraindicated? The answer is yes. But I want to let you know on the side, every once in a while, like today at the VA, a patient was on Celexa and they had bipolar disorder, and it was okay. It was not causing mania. It was actually helping the patient. No idea why. They had tried everything else, but this one worked. But in general, do you see what I mean? Because there's always those little things that you never know. So please remember that, because you could catch something. I catch it all the time at work. I'm like, hello, no wonder they're manic. Look what they're on. Look what they're taking. And people overlook it all the time. So John, what you just said is exactly right. That can absolutely help rule things out by prescribing a medication. So yes, you can prescribe a medication, even if you do not give the diagnoses in that moment, because we need time, right? Or in my personal opinion, a good psychiatrist or physician, you need that time to actually get to know the patient, talk to them, know their history, know their family history, get to ask about their childhood, right? Ask about things. So did that answer your question, John?
Yeah, no, it did. I just wanted to make sure that that's what my understanding
Yes.
was, that I was kind of on the right path.
You're exactly on the right path. Yes. Very good question. All right. Any questions about the serotonin and bipolar? Nope. Okay. Thank you. What time is it? 2:21. Okay. We're not going to go over this. Nope. Not going to do that. We already know this, right? Depression and anxiety are often associated with one another. That doesn't mean it has to, but they are often. So if the word often is thrown in there, that would be the right answer. But if I said 100% of the time, if you have depression, you will have an anxiety, is that true or false? That would be false, right? Exactly. We already know that. We already answered this. Dopamine is what antipsychotics work on, because we talked about dopamine having to do with schizophrenia, which is a recall. Now I'm going to call on someone to see if they know what this is. How about little Katie? Where are you? I don't know if there's more than one Katie. Katie, but her name's not really Katie, but we call you Katie. What is agoraphobia?
I have no idea.
Is that your voice? That's not your voice.
It's the microphone.
Oh, okay. I'm like, that's
Yeah.
that's okay if you don't know.
It has the suffix aphobia, so it has to do with some type of fear.
Excellent. So
I have no idea what the prefix is.
but that's okay. What you just did was really that's a really good thing because you're able to at least notice part of it. So when you're taking your NCLEX, I mean that could have got you the answer right. So, and we haven't really talked about agoraphobia, so that's one reason I threw that in there. Kenneth, are you on here? The loud Kenneth?
Yeah, I'm on here.
Okay. Do you know what
What's up?
agoraphobia is? Well, what's up?
Is it like? Well, I'm gonna be honest. I just Googled it, so
Of course.
it's like
Thank you.
the fear of places and situations that might cause panic, helplessness, or embarrassment. An example that I saw was like some people might refuse to leave home because it might cause anxiety and stuff like that.
Exactly. So excellent. And thank you for looking it up. That's totally fine too. This isn't a test. Or even if it was, I give open book tests. So so agoraphobia is, yes, it's fear. It's a fear of something. And how I usually like to explain it is because it can be very, very specific. Agoraphobia is basically a fear of large spaces a lot of the time and like being around people. Basically exactly what Kenny just said. And a lot of people usually have trouble leaving their home. So it's a fear of being, usually if I was going to test you on this, I would more so ask, first of all, what category does agoraphobia fall under? Is it a mood disorder? Is it an anxiety disorder? Is it a substance use disorder? Is it a chemical disorder? I put it on your study guide. I think
Anxiety, right?
it is very good. It's an anxiety disorder, which makes sense, right? Because you're fearing something. So a lot of the times medication will be prescribed for these individuals. It may be a long-term SSRI to help with the long kind of that generalized anxiety. And then on top of it, they might prescribe a benzodiazepine or something like that. If you don't know what that is, you will. So yes, agoraphobia is usually a fear of leaving the home or being in public or being in large spaces. Any questions about that? Nope. Okay. Psychosis is a what, Nicole?
Wait, the other Nicole, right?
Oh God, I forgot there's two. I'm so sorry. There's so many of you. There's 60 of you. Nicole, I just called your name because I know your name. You have blonde hair. S.
Oh, detachment from reality.
Thank you. Sorry about that, guys. All right, perfect. So psychosis is a detachment from reality. We usually associate it with schizophrenia, but does it have to do with schizophrenia? Not all the time, right? Very good. Okay, we're almost done actually going through this part. I know it says 41, but we're not going to do all 41 today because that's a lot, plus going over the test. So one thing that I forgot that we didn't go over, and I realized it in clinical, is for antidepressants, such as, and this is extremely important because we want to teach our patients expectations, right? So if I'm going to prescribe a medication, such as, let's say, we're all familiar, I taught you guys about Ativan, right? Remember the A and the V, or was that just my clinical? I think I taught you guys that. So Ativan is, the classification is it's an anti-anxiety. However, the specificity is it's a benzodiazepine. So a benzodiazepine, Xanax is probably one of the most popular ones that people are familiar with. Ativan, Klonopin, Valium, Librium, I can name a bunch. There's a bunch. However, the two that I mean, hey, if we're going to remember, let's at least remember two. So the two that I like to pick on is Ativan and Valium. And that's for two reasons. Number one, Ativan starts with an A, and that's at the beginning of the alphabet, right? And then Valium is a V, and that's at the end of the alphabet. So what is the difference between, why are there so many different benzodiazepines? And that's because they have a different half-life. So A is at the beginning of the alphabet. So why I'm using this, I guess this would be kind of a mnemonic or way that to remember it. Do you think it has a shorter half-life than Valium or a longer one? A being at the beginning.
Shorter.
Exactly. Very good. So that was Alejandro, I believe.
Yep.
Yep, perfect. So Ativan has a shorter half-life, Valium has a longer half-life. They're both considered, again, anti-anxiety medications, specifically benzodiazepines. They do have the potential to be addictive or habit forming. They have the potential. Again, that doesn't mean you're bad if you're taking it. It's just not really meant to be taken every single day or yeah, we'll get more into that. And again, if you're taking that, there's no judgment there, or it's helped many people. And I think it's a good medication, even though I work in addiction. I think it's a great medication to have. However, I think we overuse it and they are extremely hard to get off of. So, but they're extremely helpful too. So what I want to talk about is SSRI. So antidepressants, how long do they start? How long does it usually take for them to start working usually? So we have to kind of give a time frame. Can I pick on you, Drew? And it's okay if you don't know.
What was the question?
About how long would you say an antidepressant, SSRI or SNRI, like Celexa, Lexapro, Prozac, about how many days or weeks does it usually, there's like a time frame that they start to work? We haven't even gone over it yet. So
Isn't it like 2 to 3 months?
you got the numbers right. So it's about
2 to 3.
so there's two answers, but so 2 to 3 weeks usually to start working. And so but then there's a maximal amount of like how much it's going to work. So usually people will start to feel better. They might feel a little bit more like, hey, I kind of want to get out of bed today, or you know what, I'm finding a little bit more joy in this, or maybe a little bit of weight lifted after about 2 to 3 weeks. Now there's an end point to that, and that's 5 to 6 weeks. So usually, I'm going to repeat it again. I'm going to be very specific because of number 8 on the test, which we'll talk about. Talk, not argue. I think it's number 8 in your guys' class. You guys all know you got number 2 right? I don't know what I was thinking. Sorry about that. So an antidepressant usually takes about 2 to 3 weeks to start working. However, it can take up to 5 to 6 weeks to start working and or to reach the maximal effect. So after 6 weeks, it's pretty much reached its limit. So if it's not working at that point, usually the physician may raise the dose. Usually that's what they'll do, or they'll switch the medication. So I'm going to say that one more time. Starts to work at about 2 to 3 weeks, maximal effect 5 to 6 weeks. Is that good? So basically what Drew said, but he put it in months instead of weeks. Is that all good? Okay. And that's important. What if I told Drew, hey, I'm going to give you this medication. And usually I like to tell people, because some people, they don't even know what it feels like. And I'm doing air quotes, to feel their normal, whatever their normal is. They don't even know. So it's like, they don't know how am I supposed to be feeling? People have asked me that many times, and it's really important to be able to give some sort of answer. That's why I like well-being. I like that answer, but I usually will explain to them, you might start to feel like that, like I just had mentioned, the weight lifting off your shoulders, things becoming a little bit easier. Maybe your appetite will be different. It'll be the opposite of what it is now. So if you're not feeling hungry, or you're feeling like you're eating too much, things like that, you'll start to notice little things. We don't want to give this expectation of you're going to feel euphoric and amazing and you're going to want to run a 10K. Maybe, but we don't want to do that, because we want to give the correct expectation. So excellent. Any questions about that? Okay. We're only going to do about 2 more, take a break, and then go over the test. And then we are done for the day. And I mentioned what to remember, right? Like the things I wanted you to remember. And the other ones I said, wait till we'll talk more about it later. I did say that, right? Anyone?
Yes.
Thank you. Who was that?
Zuli.
I knew it. I'm like, that was like a hurry up. I want to go in and out. All right. Same thing with SNRIs. Because it's an I'm gonna, if I ever use the word in a test, I would just say antidepressant, just so you know. How long do antidepressants usually take to start working? 2 to 3 weeks. Usually. Some people are really lucky and they start to work in a couple days. But again, we're going off what I just said, 2 to 3 weeks. Okay. We're just gonna go over a couple of these, take a break, go over the test, and then we're gonna bounce out. What is the other name for Benadryl, Jihad? Ooh. Maybe he's at In and Out. Okay. Okay. I'm gonna text him something threatening later. How about Amanda J?
Like diphenhydramine.
Yay. No, yes, excellent. It's a really hard name to say. So the other name would be diphenhydramine. I do find that to be important because we do actually, this is prescribed a lot in mental health. And Amy Y, I think it's said Amy U. Can you tell me what is the off-label use of Benadryl?
For sleep or nausea.
Oh, dang, you remember nausea. Very good. Excellent. That is true. Very good. I just threw Tylenol in here. So remember, gabapentin, the max daily dose is how many milligrams? Anybody? Gabapentin is 4,000 milligrams a day. That's the same as Tylenol. So I just thought, let's throw that in there so you can remember both. Might as well. Extra knowledge, right? Okay. So does anybody remember, are these SSRIs or SNRIs? Prozac, Lexapro, and Zoloft.
SSRIs?
Excellent. Who said that?
Zainab.
Oh, Zainab?
Mhm.
Oh, I'm like, I know you. You're mine. Yes, that is exactly correct. So Prozac, Lexapro, and Zoloft. You need to know that. Those are SSRIs. Now, I'm not even going to move it to the next slide. What are the 3 SNRIs? There's 3 of them. There's like 5, but there's 3.
Cymbalta, Pristiq, and there's one other.
Very good. Cymbalta, Pristiq, and the other one starts with an E.
Effexor.
Yes, yay. Okay, good, good. Very good. So I don't expect you to remember every medication in the world, but again, hey, if I can have you leave here remembering like, or at least recognizing like 35 medications, that's pretty damn good in my personal opinion. So Prozac, Lexapro, and Zoloft you need to know are SSRIs. Now, if I asked you, what is the classification of Prozac, Lexapro, and Zoloft? You would say it's an antidepressant, correct? Because that's what these actually are. They're antidepressants. That's a classification. Does that make sense? Now, specifically, what type of antidepressant they are, then you would say SSRI because there would be nothing else to say. But if I say classification, it's antidepressant. Does anyone have any questions about that? I just want to make sure it's super crystal clear. Okay. And same thing with the SNRI. So if I said, Cymbalta, Effexor, and Pristiq, what is the classification? They're antidepressants. And then if I said, what type specifically are they? You would say SNRI. I would make these multiple choice. I wouldn't make you like remember them like that. Very, very good. Okay, almost there, almost there. Okay, Wellbutrin. How about Maxwell? Did we go over this, guys? Wellbutrin, I think we did. What type of medication this is, the classification?
I think it's an antidepressant.
Exactly. Very good. It's an antidepressant. Exactly right. What is one of the cool things? How about someone from my clinical group? Because we've talked about this a lot. Sean, are you on here?
Hello.
Hello. can you tell me what is one of the really cool things about Wellbutrin? Yes, it can be used off label for things, but it doesn't cause this. So a lot of antidepressants cause one particular thing that a lot of people obviously are not happy about, but Wellbutrin does not. And it has to do with in the bedroom.
Sexual dysfunction.
Yes, because it doesn't have to be in the bedroom, but yes, excellent. Very good. So that would be, I think, something important to know, right? Very good. All right. Last but not least for today on Medication Madness, gabapentin. Julie B, can you please tell me the actual classification of what this medication was actually made for?
It's an anti-seizure.
Excellent. Oh, you have a nice voice. Excellent. And you all have nice voices. I just don't get to hear them all the time. And then can somebody tell me an off-label use? Do you say Romel?
It's Romel.
Romel?
Yeah.
Okay. An off-label use for GABA?
Alcohol withdrawal.
What was that?
Alcohol withdrawal.
Did anyone understand that? Sorry, it's
He said
He said
alcohol
alcohol
withdrawal.
Alcohol withdrawal is what he said.
yes, thank you very much. Actually, yes, that is. And we haven't talked about that very much, but you're absolutely right. And we will talk more about it, but that's absolutely right because it's anti-seizure and seizures can be caused, if you are coming off of alcohol, you can have a seizure. So that was kind of nice outside the box. And some other off-label uses could be for insomnia and or anxiety. So that would be important to know. So this specific reason, or sorry, classification for gabapentin is anti-seizure, but you might see in a MAR where it says, give gabapentin as needed for agitation, insomnia, anxiety, alcohol withdrawal. And I'm going to add one more, and we'll talk about this more when we talk about addiction. It actually is now being used from, I'm not even going to give a milligram. Let's not make it more complicated than it's already been, for anti-craving for alcohol. They're now looking into that as though it's really helping. I'll just tell you the milligram, but I won't ever test you on it. From about 800 milligrams to 1600 milligrams, it's been seen to help with alcohol cravings, which makes a lot of sense once you start watching the videos and we talk about where alcohol goes in the brain. GABA is in your brain, and this is one place where it goes. So that would make sense why, if you're helping to fulfill that area, why it would help cravings. So it's kind of cool, right? Okay, so we're going to stop with the medication madness and kind of the review part. I told you what's important to know for now. Next week, we'll probably finish going through it because we're starting addiction and addiction is coming up. Does anyone have any questions on anything that we've gone over from this so far? And let me look at the chat. Are you guys like signing off right now? I keep hearing done, like I'm done with you. Yes, you are. I used to have 60 all the time. You guys are stressed, huh? I can feel it. I am too. Okay, so we're good with the everything that we went over so far. You guys feel good about? Okay, perfect. So it's 2:41. What time does this class normally go to? Like, it's supposed to go to 4:15. We're not going to go to 4:15, but 4:15, right? It's been so long, I don't even remember. Is that right?
Yeah,
I don't remember.
I think that's correct.
I love it. I don't remember.
I think it's 3 hours from.
Yeah,
what
it's a
we
long
were-
time. I know that. I mean, I can do it, but let's go ahead and just take a minute. And then when we come back, we'll go over the test. Again, it's a learning opportunity. I want you guys, please, 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 if you can, we will not spend the whole time on it. If you can stay on, I think that's more beneficial than leaving and then watching the video to see why you got it wrong, because I would like some interaction. I know we're all exhausted. I still have to make a video. I have homework. I totally understand from my point of view, but I really, 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 really want to make sure everyone understands because this is, I think, important for us to be able to review your test. So let's take, it's 2:42. Let's come back at 2:52. Go stretch, do whatever it is you need to do. Is that good? And I'll pause it. I'm
Sounds
looking at,
good.
I'm looking at Drew and Sean right now. So you guys are on my camera. Awesome. All right, guys, I'll see you at 2:53. All right. Okay, so for those of you who have not been here, we're on question 9. I'm going to make another video. I forgot to press record. My apologies. And I'll post that as well. So we'll continue now. Number 9, the answer is, do you have trouble controlling your thoughts? That is the answer. This will be on the final. Please know it. Okay, moving along. Okay, this one was a little bit of a mixture, and I want to explain it. So I put on the sheet for what to study about developmental stages of around life or something toward that. And I really want you to understand which one is correct and why, because this is very, very important. And this one will more than likely be on your final too. Because it's very important for therapeutic communication to understand people's process of development and kind of realization, like, I know I'm not going to live forever. So who you would approach out of these 4 people is very important as far as like looking more into how they're feeling. So the first one has to do with wanting to spend as much time with their grandchildren as possible. I realize it will not be around forever. This is actually a positive statement because it's telling me that the patient is aware that they're not going to live forever. So they want to take advantage of all the time that they possibly can. Of course, I'm not going to choose an answer yet, but I like that answer. It's a good thing for a patient to have that realization. Because the question's asking which one I'm going to intervene, which one am I going to talk to, what patient am I going to talk to? The second one is, if I could live my life over, there are so many things I would do differently. Does that sound like regret to you guys? That sounds like regret. Like this person is having some regret. So I'm going to definitely keep that one here and see what else we have to choose from. The next one is, even though I did not graduate from high school, I always was able to provide for my family. Same thing for me as far as, I mean, if you had to compare number 2 and number 3, which one would you think needed an intervention? Number 2, because the person's not saying, oh my God, I didn't graduate from high school. My kids suffered, they didn't get food. They're saying I was always able to provide for my family. So it's not like an immediate thing that you need to go see that person because they're having a bunch of regret and whatnot. So number 2 will still be I wish these were numbered, sorry, they're bubbles, is more pertinent. And then the last one is, this was the 2 I think that were most popular, was the one that was right. And then this one, I feel I have good advice to give my children, but they do not always agree with me. That's pretty common, that your children won't always agree with you. Now, if it were worded different, if all of these were worded a little bit differently, it could have changed the answer completely. But if you had to pick one, which one is regret and which person you would go to actually talk to, who would you talk to first? Like if you had 4 people on hold on the phone and they were calling in just to do a check-in, and the CNA came up to you and said, oh, this person said if they could have lived their life over, they would do things differently. That would be the person I would want to see first. Does anybody disagree with that? Or have anything that they want a clarification? And this is really important too, no matter where you work, because we knowing who to see first is going to be a really big priority. Can you see now, if you didn't get it right, why the answer is right? That's what I'm hoping. Okay. This will probably be another one that you'll see again. Most of the NCLEX questions I do put on the final. So that one was an NCLEX question. This one was straight from the book. What age does suicide peak? Middle age as well. what, at what age does suicide peak? Middle age, as well as what age? What other age does that happen? And that's at 75 years old. And that's straight from the book. So there's 2 peaks of suicide, middle age and elderly. And we talked about why, and you guys wrote a little bit about that. Real quick, I did not realize something that I want to make sure that everyone understands. So there's that medication called Invega. I didn't know they made a suspension one. So no one got anything wrong because of it, but I did want to mention. So the one that we give is 1 month, but now they have a new one. It's a suspension that lasts for 3 months. So just want to throw that out there. Invega, the injectable form of an antipsychotic, can, depending on which one you get, if you get the one that I know of, and I never heard of the other one, that lasts for 1 month. But now they have an even longer suspension that lasts for 3 months. Didn't affect anyone's grade, but I was misinformed. And when I was lecturing, I said 1 month. So sorry about that. So now we all know. So what antipsychotic can be given to, this is exactly what I'm asking, for schizophrenia, and that would be Invega, because Invega is the only antipsychotic on here. Vivitrol is for addiction, gabapentin is for anxiety, and naltrexone is for addiction. Okay. And yeah, everyone got this right. Why suicidal ideation may happen at an older age. Everyone got that one right. Any questions about that? Everybody got number 14. Any questions about that? And for the 7 people that I haven't graded, if you yet, but I will right after this, if something does come up because you don't know if you got it right or wrong because it was a typed out one, please text me and I'll help. I'll clarify. Is this the breast one? Oh yeah. Okay. All right, guys. So the nurse cares for a young mother scheduled for a breast biopsy. So this has to do with therapeutic communication. The client tells the nurse, if I lose my breast, I know my spouse will no longer find me attractive. Which response by the nurse is most therapeutic? So I want someone else to read these out and tell me what they picked and why they picked it. This is a very sensitive, I mean, they're all sensitive topics, but this one really, you will see this again.
Can I take a stab at this one? Because I think I got this one wrong.
Please, absolutely.
Okay. Yeah, so when I was reading through this one, it was trying to find the most therapeutic response. I was going through them, and then the one that came to mind was, I understand why you are upset, but after the breast reconstruction, your breast will look normal. I think I chose that one because when I was thinking about breast reconstruction, from my understanding that the physician that's doing the surgery normally tries to make the breasts look relatively similar once they've done reconstruction.
That is true.
So that's why I was thinking that one. When I was thinking the other one that I didn't think that you should focus on getting well, your children are young and they need you. That one just didn't feel right. It just
not.
Yeah. And then the other one, wait and see your spouse's reaction before you get upset. That one just felt for me that it kind of was just
dismissive, right?
Yeah, more looking to the future, where it's not really like actually talking about the moment at time.
Exactly.
And the other one that you have concerns of how your spouse will think of you. I just didn't really think that one was a good enough response, so I chose the reconstruction one.
And interestingly enough, I think that was John, correct? So
yes, that was John.
Interestingly enough, a lot of people tend to pick that one. And can somebody, so the actual answer is you have, I think it probably told you, you have concerns of how your spouse will think of you. And that has to do with validating that you understand what the patient is actually asking. And that's why it's right. The other two are not validating. And the second one's just kind of like, that's not your place to say. It's rude. It's not therapeutic at all. Now, coming from the place of the actual person who would be doing the breast reconstruction, not the nurse. So the nurse being therapeutic, if like I was the nurse and giving a therapeutic response, if I were to say, I understand why you are upset. First of all, we never say, I understand why you are upset. Or I don't want to say never. It's usually best not to say, I understand why you are upset. Because maybe we don't. right? Maybe we don't know exactly why they are upset. That's why we usually try not to say why or kind of question things. But we also can't guarantee that your breasts are going to look normal, right? And what is normal? Normal to me, I mean, and I know I'm not trying to actually be funny, but maybe to me, a size B is going to look normal and beautiful, but they're going to have tattooed nipples because they had breast cancer and they had to remove the nipple. But somebody else is like, no, normal to me is a double D. I mean, there's so many variations of that. And what is normal? So a lot of people did pick that one. I purposely did not go over this one because I wanted to, it's a good learning experience as far as therapeutic communication, but can somebody else in their own words, other than just me, please explain why they wouldn't pick number 3 without obviously like demolishing the people that did?
Can I try it?
Please.
So I chose the you have concerns of how your spouse will think of you just because out of the 4 that seemed it like the choice. But I think for me, from like a perspective as already being a woman, and I think I kind of get like a different look at it. So like, even though I guess for a man, normal is different, but for us, it's like we notice every little thing that changes. So it's not really ever going to be like normal again because it's such a big change. Even if it looks normal to other people, like if I were to get some reconstruction, it would, to me, I would still look completely different because that's just how I would see it.
You actually just sparked a really good thought. So I personally, and I can't say like book wise, but I personally agree with you. And it's kind of like, and in all just being serious, but kind of not funny because this isn't funny, but if I said, hey, John, we're going to cut your penis off and put another one on and we're going to reconstruct it because people get penile cancer, right? I don't actually know what they do with that. Oh God, the chats are, oh my God, it's going to go off here. But no, I mean, truly, I mean, and with the first class, I said something different. I was like, what's interesting, and I'm being very honest, it's actually more of the men in this class, and this isn't me being sexist or anything, actually got this one wrong. Than the women. So I don't know if it had something to do with that, but maybe there is something to that. Does that kind of connect anything, John? And sorry, we won't take your penis, but God, I'm gonna get in so much trouble if anyone ever sees this.
It makes sense. I mean, I guess the whole aspect of Anna had a really good point where, I mean, I'm not saying that this is for all males, but yeah, it kind of is an interesting thing that looking normal is going to be very different in that regard, where it's like, what is normal in that sense?
Right.
So that does make sense because that could be it can be one side of the spectrum versus a whole nother.
Exactly. Beautifully. See, I like when the students, how you guys just did that together. I really love that. So the answer would be you're verifying. Oh God, I have to look at the chats. Sorry, we won't take your penis. Oh my God. Oh my God. Please, on your if you guys do that thing, what's it called? The evaluation. John's gonna put, Amanda said, we're gonna take my penis. Oh Lord. But that was Anna, right? That said that? Not the penis part, but the reconstruction part. Okay, very well said. So the answer would be you have concerns of how your spouse will think of you. So you're validating. We know number 1 and number 2 are definitely not right. Number 3, we're kind of giving false reassurance. Really, that's what it comes down to. It's false reassurance. And we definitely don't want to give false reassurance for anything, right? So that's why it's this one I always spend more time on. I don't know why. I think kind of what Anna was saying, it's a really sensitive thing, right? I mean, you're removing a part of your body that it kind of, for a lot of women, make them feel like a woman, right? So, okay. Not to everybody. I said some. Okay, the nurse, let's move on. The quote of the day, oh God. You guys, I can imagine at graduation, there's going to be like t-shirts and oh my God. Okay, hey, they asked me to do the Nightingale Pledge for this last semester and this semester. So I'm doing something right. Number 16, the nurse provides care for patient in the emergency room. Which client would you see first? NMS, we talked about that in pretty good detail, that would be the most life-threatening when a patient is on an antipsychotic, right? Because your patient can die and stop breathing because of the rigidity of the muscles, and temperature goes all over the place. Any questions about that? And TD and akathisia are pretty much almost the same thing. And the patient who's expressing the grief about the mother didn't say anything about SI or, hey, I'm going to kill myself right now and there's a knife to my wrist. So the answer would be NMS. That will definitely be on the final as well. Oh God, I have to read this. I couldn't interject in time. Better just Exactly. Very good. Giving the false reassurance. Exactly. And that can be, seriously, that is so hard. It is so difficult sometimes because we want to say it's going to be okay. Don't worry. We have a great plastic surgeon, or it's going to be okay. You're going to be okay when someone's crying in front of you. That is one of the hardest things. If you guys watch that video about therapeutic communication, and I have to stop myself all the time because I want it to be okay. I want to take out a magic wand to make everything okay. But that's why we do this practice and why we go to clinical, because we're nurses, we're healers, right? I mean, that's hopefully why we went into this, is to help people. Very good. Exactly. 50, you guys all got this one right. 5150 compared to 5250. Excellent job. I don't think I'm going to ask that one again. It takes way too long to grade to read through it. And I think you guys got it. Number 18, which is this about, okay, this is very important. What I'm going to say about this. So if you have a patient, I'm going to use a med surge example. So you have a patient that is in a 10 out of 10 pain. They do not feel good. Are you going to do patient teaching at that time? No. The patient is in a ton of pain. I'm not going to do patient teaching. That's not the right time to do patient teaching. They're not going to more than likely receive it. And it's just not really nice, right? So kind of same thing here. If we have a client that is extremely escalated and escalates to verbal abuse and then starts threatening people, if we tell that person in that moment to calm down, do you think they're going to get more pissed off? More than it's not a therapeutic response. Please calm down. However, let's keep reading because we don't know. Maybe the other ones are worse, but that's usually not something we're not going to say, please calm down, or tell them the unit rules, or you have to imagine being so mad think of a time in your life where you were so just pissed off and someone tells you to calm down. It's like, you better get out of my face, right? And especially if you have a mental health issue going on at the same time or on medication. Madison agrees with us. So the next one will be call the client's family to come to the facility. That's called passing the buck. We don't do that. So we're not going to pass the buck onto the family because the patient's within our facility. So it's our responsibility. So don't forget passing the buck. That is an actual thing for the NCLEX. Put the client in a quiet room, supervised. Love that one because we want to bring down the stimuli. And if it says supervised, so they're being supervised, we're bringing down the stimuli. So hopefully they will calm down to a point where we can then have a therapeutic conversation. And then the next one is one that a lot of you did answer, not more than 30%, but explore the cause of the client's anger with the other clients. There are a couple reasons why we would not do this. And if someone from my group, I want someone from my clinical group to answer this. We talked about why. There's 2 reasons specifically. We talked about this. I'll say one of them, HIPAA. What's the other one? So these patients are in a mental health unit. Do you think that they're mentally healthy? Maybe in this moment? Possibly more not likely if they're there, right? So exploring the cause of the client's anger with the other clients, number one, it's just not appropriate. Number two, you could be violating HIPAA. And number three, you're asking patients that are in a potentially in a psychotic or very, very anxious or all of these other things. That's not their responsibility to ask them, basically. So what is our number one thing? Safety. Safety. So we always want to think safety. What is the safest answer here? Let's remove this client and let's hopefully release some of this stress. If this didn't work, then we would have to give an injection, right? A cocktail to calm them down. Does that make sense why it's not number 4 now? For those of you who picked that? Okay. Because remember, this is an NCLEX question, so it'll probably be on your final. Okay, the next one. So there were two that I was a little bit kind of like, I was a little confused about. So on this one, so we talked about this. So if someone says that they are feeling like they're going to kill themselves, what is the very first thing you ask? Do you have a plan? Always. And I have mentioned that several times. So do you have a plan? Then you could possibly ask maybe, you know, what's going on? Is there a reason why, what's making you feel this way? But immediately, I want to know if you have a plan. Because if you say, I have a plan, I have a paper clip in my pocket and I'm going to run down the hall right now and slit my wrist, that's safety, right? So always, if someone's having suicidal ideation, the first thing you ask is, do you have a plan? If somebody says I'm having a hallucination or an auditory hallucination, the first thing you ask is, what are the voices saying, right? Not, has this happened before? That would be more like the second question. Because I want to know, are the voices saying punch Amanda in the face? I had that actually happen last week to a student. The voices were telling the patient to tell the student to please stop talking to them at the VA. And that perfect, because she asked, what are the voices saying? And that's how it happened. And so the student said, okay, if you need me, I'll be here. I'm happy to come back and talk to you later. Any questions about those two things? And we've talked about them before. And okay, you'll probably see those again too. Free question. I gave you a free point. Yay. You guys were so sweet, by the way. Everyone was like really nice. One I took a picture of and you made me cry. I won't call you out, but it was someone I graded last night. This one, the lowest score was a 4. So a couple of people got a 4. And then, so I want someone else to answer this. So if somebody is escalated and they're angry and someone's feeling disrespected and, you know, do you want to ask a lot of questions all at once if someone's pissed off? You want to keep it short and simple and open-ended, right? Not why, or why, what, here, when. And however, that's why we're still practicing and learning. That's why I was like, I'm not going to give anyone lower than a 4 because we're still practicing. So are there any questions about this? There were a lot of really good answers. And I even put some little notes in there like, this is perfect. It's perfect. Like, and then other people put like, I would remove the patient from the situation and ask them, would you like to speak about what's going on and how you're feeling? Just that simple. It can be that easy. We just don't want to ask a lot all at once. Again, imagine you being mad. Would you want, or not feeling well? Let's say you have the flu and you just threw up and someone's asking you 100 questions. That would be agitating, right? Any questions about that one? Okay. You guys did a really good job. And personally, I think that's one of the hardest questions. And I was really, I was very pleased with what I read because I feel like you're really getting it. I hope you're using it in clinical or using it now if you're there. What medication classification is gabapentin? A couple people got this wrong and I almost called you personally on my cell phone. Someone say it.
Antidepressant.
John,
Oh, whoops. I meant anti-anxiety.
No.
I don't. I'm not
Benzo. It's
What
a
is?
benzo.
No, it's not.
Anti-compilation.
Thank you. I really needed that.
I actually
I'm not-
I got
I'm
that
not-
one right on the test. I promise.
I'm not laughing at you guys, but it's so funny because of what I just said. Okay. So this will be good for the next test. So the classification of gabapentin means what was gabapentin actually made to do? What is it classified? If you looked it up in your drug book, what is the classification? It's an anti-seizure medication, which is also called an anticonvulsant. However, we can use it off label for anxiety. Any questions about that? Oh, and it's funny too, because John and Drew are like right by each other. So it's like a comedy show. Okay. We're almost done. Which of the following can be used to help with anxiety off label? Propranolol and gabapentin. Cogentin, what is that used for? That's used for too low of dopamine when somebody's put on an antipsychotic, and it helps with like the pill rolling, the tongue rolling, all of that kind of stuff. So it helps to offset those symptoms. Propranolol is a beta blocker. It helps to lower the heart rate, so that can help with anxiety. And then gabapentin, we just talked about, its classification is a what, John?
An anti-seizure medication.
Excellent. But we can use it off label as an anti-anxiety, and it's not habit forming, which is great. See, I told you now I'm going to say habit forming the whole time. And or the other one, addictive. Okay, so this one, I wasn't trying to trick you, but I did flip it and said, where is 10% of the serotonin in your body? So where's 90% of it?
In the gut.
Yep, in your gut. So hopefully where's the other 10% if it has to do with mental health?
In your brain.
In your brain, yes. Any questions about that? Nope. Okay. So I may on the final, if I ask that, I may flip. So please read it because I may flip it around and ask it the other way. So don't just assume that I'm asking the exact same question. What did I do? Okay. We already talked about this. If you're hearing voices, what is the first thing you're going to ask? And that is, what are the voices saying? You want to know what the voices are saying? Then I would probably ask, oh, have you heard voices before? And, become very therapeutic about things because I want to know what's going on for patient safety. This one, this is the same one as the one above, Cogentin. So Thorazine, I put a list of medications that we hadn't talked about that were antipsychotics. Thorazine was one of them. So upon assessment, you're seeing Parkinsonian. I described it instead of just saying they had it. And so it's going to be the same answer as the first one, which is Cogentin, because they're having Parkinsonian, tremors, tongue rolling, all of that. Any questions about that? Okay. Number 27, I gave credit for both ways. Half of you answered it one way and the other answered it another. What I was looking for was to ruling out things if someone has depression, such as like testing the thyroid and vitamin D levels. However, most people, I would say 75% of you answered it, read it in a different way. That's why I gave both 2 points, whether you answered it one way or the other, which is other things that could lead to depression. Like, I can't even remember in the moment now, but like, give me examples because you guys answered it. What did you say here? Physical things.
I think I put like oversleeping and appetite, something like that.
Yeah. So people put like symptoms. So people put symptoms. I gave it to them because I'm like, there's got to be something there, right? If I ask this question again, I'll be more specific, but I don't think I am. But it's important to rule things out. Please just remember that, because you could be treating depression, but really their thyroid's off, right? And we want our people to feel better. Okay, true or false? An example of a somatic symptom of anxiety could be headache or chest pain. Is that true? Or stomach upset? That would be true, right? Because somatic is the body If you're anxious, your stomach can definitely be upset. A lot of people get IBS. You can have palpitations, muscle aches. So that would be true. Sound like I said Drew. It could be true. This one, everybody got right. The frontal lobe is where, and this will come in with when we start talking about addiction. We'll talk about this critical thinking and judgment. Where's that mainly responsible for? And that's your frontal lobe, which addiction does a lot of changing to that part of your body. So far, any questions as we're going through? We have 6 left. And it's 3:49, so we'll be done in about 5 minutes. Which of the following is an example of dual diagnosis? So just a reminder, dual diagnosis has to do with a diagnosis of something with an addiction. So alcohol use disorder, methamphetamine use disorder, cocaine use disorder. So some sort of addiction, and then mental health like anxiety, bipolar, schizophrenia. So depression and oops, I'm taking the test too. I got it wrong. Okay. Does that make sense now? If it didn't before? Okay. And you'll probably more than likely see that on your quiz because we will have talked about addiction at that point. So please know this one. Okay. I want you to get it right. And you'll see this in the community a lot. Everyone got this one. Why are common stomach issues when medication is started? You all answered it a little bit differently, but you got the point right, which had a lot to do with serotonin being in the gut. So as long as you were within the realm of somewhat right, I gave you the point, or however many points that was worth. True or false, the neurotransmitter norepinephrine is being utilized properly inside one's brain, we would hope to have the patient have increased energy and motivation. Is that correct? Yes, that is correct. What about serotonin? What should we feel? My little hand gestures. Starts with the
Sense
double.
of well-being.
Sense of well-being, exactly. And then norepinephrine is energy and motivation. Okay, number 33, which of the following is a mood disorder? So some of you did get this wrong. It was on the study guide very specifically. So please look at the study guide. I'm trying to help you. I want you to do well and remember it. So which one of these is a mood disorder? So schizophrenia, that's a chemical disorder. Anxiety is an anxiety disorder. Substance use disorder is a substance use disorder. So which one is a mood disorder? There's only one left.
Depression.
Thank you. Depression. Yes. So under mood disorder thus far, and I'm, like I said, I'm making a chart for you guys. I put bipolar disorder and depression. So far, those are the two that you know that are mood disorders, depression and bipolar. And it doesn't matter what, if it's bipolar 1, 2, 3, or 4, there's 4 now, or cyclic or whatnot, which I will teach you. Okay, which of the following is considered an anxiety disorder? I think you all got this right. PTSD? Anyone have any questions about that? Definitely anxiety. I mean, if you've ever met anyone, especially being at the VA right now, oh my God. It's really, it's something that I was not exposed to as much, and I've learned a lot about, more so. So PTSD is considered an anxiety disorder, just like agoraphobia and OCD, which I think I put all on the thing. So which of the following is an antipsychotic? Remeron is an antidepressant, Wellbutrin's an antidepressant, Prozac is an antidepressant, Invega is the injection that can last either 1 month or 3 months, depending on which one you get. And then last but not least, you all got this right. And see, I'm spinning here. It's the injection. And again, I got a kind of different realm of answers, but as long as you said something about injection or antipsychotic, or I knew that you knew what you were talking about, I gave you the point. But really what I was hoping for is what is an advantage is because getting the injection, you don't have to take a pill every day. And those that suffer with psychosis, usually we link that to schizophrenia, even though it doesn't have to be. will have paranoia potentially. So they're less compliant with their medication. That's what I was looking for. But as long as you were in the realm, I gave it to you. So understanding that it's an injection and it lasts longer, that's what most of you said. And everybody got that one right. So any questions, concerns, anything anyone wants to say about the test? You only have one more test in this class, a couple more quizzes. It was pretty good. Did anybody cry after? No tears, hopefully. Okay. And if you ever have a concern after a test, I had a few people email me, feel free. And very respectful. I'm going like this because there's a fly, sorry. Very respectful, just asking questions, and one actually caught number 2 being wrong because I totally did not see it. So please feel free. I have no problem with that. I'm a human being. I make mistakes. Sometimes I may ask something incorrect, whatever it may be. So just let me know and we'll get it fixed, or I'll explain to you why the answer is the answer. So I will go ahead and change the dates that we talked about already as soon as we get off, which we're getting off right now, unless anyone has questions. And then I will record the first 8 as well, and then put that on there. So does anyone have any questions about the first part where we talked about some new medications and terms, and or the test? Everybody has an A in the class. You're making me look bad. So I asked Colleen, I said, am I too easy or are they just that smart? And she said, they're just that smart. So I guess it's okay. So keep doing well. And if you need of course, you're welcome, Lazuli. If you need anything, you know my number. And otherwise I will see you guys. So my new clinical group, you'll get information, don't worry, about Thursday. Or not Thursday, Jesus, Wednesday night. And I will see the rest of you guys on Friday, and I will hopefully make it not very stressful, because it's going to be a very stressful day for you. Sound good? All right, my dears.
Thanks,
will.
Amanda.
You are so very welcome. You guys have a great weekend. Good luck
Thank
studying.
you.
You're welcome. Thank you.